My name is John Abraham. I'm one of the faculty here at the Corwell Health Palliative Medicine MSU Fellowship. It is my honor and privilege to speak to you all this morning about severe pain and severe pain crises. This is a lecture that I've given the past couple of years, and so it's fun to come back and meet the new fellows and share a little bit about treating severe pain and pain crises. There is some redundancy in this lecture and the prior lectures. That is both by design and a little bit unintentional. So I apologize if there's, repeat information, but hopefully we can cover some new topics too and learn together. So there is a bit of fair warning, and I apologize for people who've seen this lecture before. There's a bit of art history in the beginning. And let's dive right into it, see if this works. Okay. All right. So starting off with our art history lesson, many of you may be familiar with the famed Mexican artist Frida Kahlo, or Kahlo. She is, a famed a painter. And the reason that I talk about Frida at the beginning of this lecture is that, what you may be familiar with her paintings, but what you may be less familiar with is that, Frida was essentially a palliative care patient as she neared end of life. She died young. She had a very difficult life, stemming from a streetcar accident when she was 13 years old, in which many people died. She was lucky to survive, but was impaled by a handrail and was confined to bed for much of her youth and had many, painful complications, many surgeries. And she actually learned to paint in bed. You can see here she has a special easel set up lying in bed. This was first introduced to her by her mother when she was confined to bed. She, in the later years of her life, she had further complications stemming from her injuries and surgeries. Her leg was amputated in her final year of life due to gangrene. And in her final days, hours of life, she was said to be in a pain crisis. She died of presumed pneumonia, sepsis. And her bedside nurse who cared for her, publicly stated that, or speculated that she thought Frida died of an intentional overdose because there was morphine on the nightstand. And Frida was allotted a maximum of 7 pills of morphine when 11 were missing from the bottle. So a modest dose increase. But, just a testament to the suffering, Frida's final diary entry was, I joyfully await the exit and I hope to never return. And her pain is represented in her work. Actually, I'm going to go back 2 slides. And the next time you see a painting of hers, you're going to notice, this is the wounded deer. It's a repeated theme throughout her work. These are sort of surrealist self-portraits. Here she is as a deer-like creature, but you see she's pelted with arrows all around her body, and we can see. In this painting from 1944, The Broken Column, there's multiple visual representations of pain. You see her, her spine has been replaced with a stone column full of cracks. She's sort of bound in this sort of corset device, presumably a back brace. And then I don't know if your screen can pick this up, but she's got nails really driven in throughout her body. And even harder to see is that around her face, she appears to be crying. So an awkward segue of sorts, but a little bit about me. I'm from Boston, Massachusetts. I am a Celtics fan. I apologize for any of you who root for the Lakers. I went to Tufts University School of Medicine in Boston. I am emergency medicine trained and board certified. Did my fellowship, my residency at U of M, and then hospice and palliative fellowship at Henry Ford in Detroit. I have no conflicts to report. The objectives of this lecture is to understand what defines a pain crisis in a palliative care patient or hospice patient. We're going to identify a strategy for utilizing parenteral opioids during a pain crisis. And then we're also going to talk a little bit about some advanced modalities that we can use if our initial strategies don't work. So what is a pain crisis? It may be one of those things, you know it if you see it, but it's severe or uncontrolled pain that causes extreme distress. It can be acute or subacute in onset, but it requires immediate intervention. So what do we do when we come to the bedside and we see somebody in distress? We got to come up with a plan, a good plan. This starts, as always, with a history and physical exam. You got to know what you're treating. Maybe the best pain medicine is morphine. Maybe the patient needs a surgeon for an emergent operation. So as much as we can, we want to understand what we're treating. Symptom crises, it requires patients who have severe symptoms, you may not be able to get much of a history. But the differential diagnosis is broad. So be aware that, the definitive treatment may not be opioids. Is this existential pain that would benefit from IDT support or interdisciplinary team support, such as your social work team, chaplain colleagues, child life, et cetera. And then other clinical things to consider are cultural differences, goals of care. If a patient says, just knock me out, or I want to be alert and have as little medication as possible. Aligning a plan of care with their goals. Some cultures place value in suffering. So it's important to check your own biases and make no assumptions as you come up with this plan. But, for our purposes today, we're going to focus on the meds. So we're choosing our medications, opioids, adjuncts, and what I tell our learners, especially when you're becoming more comfortable with utilizing these medications and sometimes serial doses of these medications. Just remember to start low and go slow, especially in the opioid naive patient. John Mulder, I think, is muted right now, maybe stepping away, but last year he said, start low, go slow, but just go, which I liked a lot. So opioids in the opioid naive patient. I'm going to give you a roadmap of sorts. And I want to, provide the caveat that there's lots of different ways to do this. This is one way. It helps me sort of be systematic and thoughtful in my approach in these patients. The scenes may be chaotic. Your patient may be screaming in pain. You may have anxious care providers or family members at the bedside who are peppering you with questions. This approach helps me stay organized and stay in a space of good clinical judgment. So an opioid naive patient, they've had some progressive abdominal pain, for example, of unknown etiology, and the CT scan shows, suspected metastatic disease. Morphine is a very reasonable choice. 1 milligram IV every 15 minutes as needed for severe pain. And expect serial doses for these plans. Hydromorphone, also a good choice. And given our sort of dose equivalency conversions, we start with 0.2 milligrams IV or sub-Q if you don't have access, every 15 minutes as needed. And really, why it's every 15 minutes, which may cause your, bedside nursing staff to balk because, every 15 minutes seems like a lot. We're starting with low doses. And, we expect our IV medications to reach a sort of therapeutic benefit or uh, maximum serum concentration reaching the brain within 15 minutes. And so if you're not seeing relief within 15 minutes, this is really a reminder to really stay at the bedside and reevaluate as much as possible. If a patient is, out of control, moaning, thrashing, maybe they're not able to provide you much history at all, you might be able to start a little bit higher. If the pain is not controlled with these very modest doses in opioid-naive patients, you can increase by 100% if you think this is going to take more. So maybe on the first 15-minute interval, you try 2 milligrams. I generally recommend don't increase more than 100%, but you'll find out very quickly whether things are working. Sometimes it's the third or fourth dose that allows a patient to achieve analgesia. So that's the opioid-naive patient. Let's talk a little bit about the opioid-tolerant patient, because this may be more challenging, a patient that you may start at a higher dose. And this requires some math. Nobody really told me that I'd be doing so much math in palliative medicine. Thankfully, the math isn't too brutal, and by the time you become a seasoned hospice or palliative provider, it comes pretty fluidly. So in an opioid-tolerant patient, they're on chronic opioids. Calculate the previous 24-hour OME total. I recommend not just going by their medication list. Be aware that they may not be taking their medications as prescribed. They may have Q3-hour PRN doses available, but they only take 2 in a 24-hour period. So to the best of your ability, clarify how much medicine they're taking. If you're rotating opioids, always account for incomplete cross tolerance, so you don't get yourself into trouble. You'll see some variability here. I like a 25% dose reduction. If a patient's very frail, maybe I'll be more conservative with a 50% dose reduction. But calculate their OMEs, do your conversions, and then take 10% of that to define your PRN dose. And then, like I said in the last slide, the follow-up or sort of like plan of action is the same. We're doing those, Q15-minute reevaluations, and then repeating a dose or doubling it if the preceding dose is not allowing patient to achieve comfort. So either by patient report or just their appearance. So let's look quickly at a case in point. So Mr. G is a 59-year-old male with a history of metastatic prostate cancer with bone mets. He is in a pain crisis, and he is on the following home meds. He is on MS Contin or long-acting oral morphine, 30 milligrams by mouth 3 times a day. And then morphine sulfate, immediate release, 30 milligrams by mouth every 4 hours. And he's taking all available doses. So do your quick math and calculate. He's on 270 milligrams of oral morphine. We're using oral morphine here because, OMEs or oral morphine equivalents is our kind of a common denominator for our conversions. And so just to make it easy here, we are selecting IV morphine because he's tolerated it well. And using your conversion, you calculate he's used 108 milligrams IV equivalent in 24 hours. And so to find our PRN dose, we calculate that 10% of that is 10.8 milligrams. If you order 10.8 milligrams, your nursing colleagues will look at you funny and curse your name silently or out loud. So you round to a tidy number that you like. In this case, we're choosing 10 milligrams of IV morphine every 15 minutes, PRN. And this is sort of anecdotal experience. I have found that in some cases you may be working with another care team member who is very apprehensive about administering 10 milligrams of IV morphine. Sometimes you can do a little bit of kind of razzle dazzle and select another opioid that has a lower number. So maybe you use IV hydromorphone and come up with a lower number that they're more comfortable with, even though you know in the back of your mind that the doses are equivalent. I want to talk about a PCA. PCAs are something that we used a lot in my fellowship. And we have been able to utilize them since I started over here at Corewell Health. So some of you are already familiar with PCAs, oh, we're moving. And for those of you who are less familiar, PCA stands for patient-controlled analgesia. It is an IV pump that the patient has control over their boluses. There's an ability to provide a continuous infusion of medications, but really it gives the boluses, IV boluses in the patient's hand. So what are the proposed benefits of this? It's ideally more immediate pain relief with fewer overall opioids. Actually, the literature supports that patients on PCAs average fewer milligrams of opioids when PCAs are utilized. It's convenient. You don't have, it doesn't require really nursing staff to run back and forth to a Pyxis. It's relatively safe. And I'll explain why in a moment here. And then the pump is a computer that records how much medication the patient is using and how well it's working. So here's a cartoon of sorts of a patient on a PCA. If you can see his face, he looks tranquil and serene, which is our goal. Patients like these devices. And, when is the right time to use this? It's for rapid dose finding. Patients can be opioid naive or opioid tolerant. Post-operative pain, it's highly utilized in hospitals. And it's good for patients where other routes like oral or sublingual medications may be contraindicated. Maybe they're strict NPO or they've had some oral surgery that doesn't allow you to give oral medications. Obviously, they need an IV or sub-Q access to utilize this. So those are some right patients for PCA. There are patients where it may be relatively contraindicated. If they're cognitively or physically incapable of pressing a button, if you hand a patient a button and they're trying to change the television station with the button, they may not be appropriate for that. Sorry, we're moving automatically here. See if I can figure that out. If patients are not expected to have access, like IV or sub-Q access for long, it's not appropriate. And then using with caution with frail populations, elderly. I'm so sorry. I don't know why it's going by itself, but we're going to shuffle around here. If they have end organ damage like renal or liver dysfunction or other comorbid conditions, OSA, morbid obesity, or they're somnolent. These are relative contraindications. I recommend being judicious with dosing and also maybe avoiding a continuous infusion right away. But PCA, just a demand only button push may be appropriate. This is the busy slide. It's just a sort of a visual representation of a flow sheet that I adopted from U of M and their palliative use of PCAs, and it has both an opioid naive path and an opioid tolerant path, basically summarizing exactly what I just said. Blowing the slide up a little bit. Um, uh, this is sort of an example of what we might see. We calculate their OMEs, and we see that that's equivalent to 60 milligrams of IV morphine. Geez Louise, I'm sorry. May have pressed something that's moving on its own. You calculate a continuous infusion. This is for an opioid tolerant patient, and you see that it's 22.5 milligrams per hour. And so your plan with the PCA right out of the gate is 2.5 milligrams an hour continuous infusion. And then usually the PCA dose, demand dose is 100% or maybe 50% of the continuous infusion. So just to make things tidy, we're doing 2.5 and 2.5. So they press the button, they get a dose of medicine, 2.5 milligrams, and you would use a lockout interval. And this is important. This is the safety feature that reduces the risk of a patient overdosing themselves. So they press a button, they get a dose of 2.5 milligrams, and then the button locks them out for 10 minutes. And they cannot press or get another dose for 10 minutes or a time interval of your choosing. I like 10 minutes, 12 minutes, 15 minutes, generally not a shorter interval or a longer interval than that. The computer, the PCA box, will record every dose that they get, but also every time they press the button and they don't get a dose. And this is important for understanding when you're looking back at the pump, how well the medicine is working. If they're hammering the button and they've pressed it 50 times and only gotten 20 doses, that might be a clue that the patient's pain is not well controlled. And here, there's different PCA devices. This is a visual representation of the Corwell pumps, the CAD pumps. And you can see that there's a reports window. You can click on this to get the data that you want to guide your further management. So you see the pen is pointing to given and PCA dose counters. And this is really where your follow-up plan is sort of formulated. So we click on that, and then we can see that this is a patient on a fentanyl PCA. In the past few days, generally we're checking these pumps every 24 hours at a minimum. They've received 52 doses on 52 attempts. So every time they press the button, they have received a dose and did not lock themselves out. Which is kind of what you want to see. If there's a big discrepancy there, you may need that may be a clue that you need to dose adjust. I want to transition here to talk a little bit about adjuncts, non-opioid options for a patient in pain crisis. Maybe you're on, monster high doses of opioids and you're not really achieving the clinical response that you'd like. Maybe they're on a competitive inhibiting medication of opioids like a high-dose methadone or Suboxone. So I want to talk a little bit about ketamine, very popular. You're going to get a lot more education on ketamine, but it's very useful and it bears repeating. Training in the emergency department, it's kind of like the Frank's red hot sauce of the emergency department. They put it on everything. It's been used for years as a general anesthetic, including battlefield anesthesia during the Vietnam War. In the early 1990s, the first reports of sub-anesthetic doses for cancer pain were documented, including reports of showing efficacy for opioid-resistant pain. It's a derivative of PCP, actually, of phenylcyclidine or phencyclidine. It's a racemic mixture, lipophilic, water-soluble, and easily crosses the blood-brain barrier. It works a little different than opioids. It's as opposed to attacking the mu receptor, like your opioids, it's a potent NMDA antagonist. And this is an important consideration when we're talking about decreased opioid responsiveness. It does interact with the opioid mu receptor, but it's not necessarily clinically significant. It's nice because it can be given IV, sub-Q, IM, orally, intranasally, although you will get different bioavailability with those different routes. So advantages, multiple routes of administration, like I said, can help treat acute and chronic pain when opioids are less effective. It's relatively inexpensive and widely available, typically inpatient, but outpatient, you can get it as well. And there is lower risk of hemodynamic compromise. And you won't get the respiratory depression that you associate with opioids. Although, anecdotally, I have had patients who have received a dose or two of opioids who then get ketamine who do exhibit respiratory depression. So, don't assume it's totally safe when giving this from a respiratory standpoint. There are some drawbacks to ketamine. Side effects being a big one, like some psychomimetic effects are probably the most pronounced. So patients may experience delusions or delirium, hallucinations. They may have nausea. That's seen in some patients. And then, as far as the literature is concerned, it may cause increased intracranial pressure or intraocular pressure. But there's mixed evidence on this. So if a patient, has a brain bleed with, impending herniation, it may be a less ideal choice over the theoretical risk of increased intracranial pressure. So again, we're going to have a separate ketamine lecture, but how do we dose ketamine in acute pain? You'll see some variable data out there, but it may be a good place to start with the anesthesiologists who've been using this medication for a long time, and their National Pain Organization and the ASA had a consensus recommendation that they published in 2018. The ketamine boluses should not exceed 0.35 milligrams per kilogram. If you're utilizing an infusion, they shouldn't exceed 1 milligram per kilogram per hour. And then for chronic pain therapy, lower doses are recommended, and that's really due to minimizing the risk of side effects. So anywhere from 0.1 to 0.5 mg per kg per hour. We do use, in our service, we do use ketamine infusions every once in a while. And we adhere to that sort of bottom line, the 0.1 to 0.5 mg per kg per hour. I want to talk about one of my favorite medications, dexmedetomidine, also known as Precedex. This was had limited utility and availability until a couple of years ago when Precedex was made available as a generic formulation. Previously, Precedex was quite expensive and therefore cost prohibitive. So if you tried to order it, you get a lot of red flags pop up in your EMR. You maybe got calls from your pharmacist. But since going generic, it has been more frequently employed in treating refractory pain in palliative and hospice patient populations. It's a pretty cool med. It's unique in several respects. The ICU uses it a lot for sedation for ventilated patients. And it has unique sort of symptom management properties in that it's a sedative, it's an analgesic, it's an anxiolytic, It is an amnesiac, kind of like midazolam is. It's a selective alpha-2 agonist sedative. It was introduced in 1999. It became attractive after it was noted to not cause respiratory depression, like some of the benzos or certainly the opioids. It's the same family of drugs as clonidine, but causes less vasodilation and more sedation, which is why it's utilized in these scenarios. It can cause bradycardia. This is more seen when bolusing dexmedetomidine. We typically don't bolus it. We've used it several times inpatient for these sort of refractory symptoms, but it's always as an infusion. Um, and it's used, like I said, for ventilated patients in the ICU. It can be used for patients who are in severe alcohol withdrawal. It is something, that you'll see less of, but a fellow and I cared for a patient at end of life in the hospital 2 years ago. They were not responding to escalating doses of opioids. We had Versed infusions. This is somebody with a substance use disorder history. And we were kind of hit our ceiling with opioids. Ketamine was contraindicated because the patient had had ketamine in the past and had terrible nightmares and hallucinations. So that was off the table. And so Precedex, we were able to get to the bedside, and it was a pretty dramatic response. We were able to cut the opioid infusions in half within 24 hours, and the patient was able to pass away comfortably. We actually published this as a case report poster at AHPM and got accepted. So you're going to see more literature come out about this medication in the coming years, I suspect. But a good thing to think about. And if it's not available, maybe talk to your pharmacist about making it available, because when you need it, it may be very helpful for you and your patients. So we're making good time here, moving right along. We're kind of reaching our conclusion. I thank you for your attention. Summary. So pain crises, there are true crises, and they need to be identified and intervened upon quickly. Remember that the best treatment of a pain crisis may not be pain medication. Maybe you're giving a couple doses of pain medicine to allow a patient to get a CT scan because they need an emergent surgery. We can give pain medicines for a lot of things, but just know that the definitive treatment of a patient's pain may not be pain medication. Remember to start low and go slow, especially in the frail or sort of compromised patients. And for opioid tolerant patients, you're going to calculate your OMEs and double check your calculations every single time. Can't stress that enough. And then in certain circumstances, when you're really kind of up against a wall, patient-controlled analgesia, ketamine, and other medications like dexmedetomidine may be helpful. And remember Frida Kahlo, who unfortunately, suffered a lot with pain, and it sounds like died in a pain crisis. You may not get a second chance of getting this right. And so being thoughtful in your approach, making patient-centered decisions to help guide you. And you're going to find that you're able to achieve success at the bedside. So thank you for your attention, and hopefully you're able to learn a little bit about some management of severe symptoms and some art history too. I thank you for your time. Some references. The slides will be emailed out to you by fellowship administrative staff. But once again, I thank you, and I will cede the floor, stop sharing my screen, and actually, before I do that, I'd like to open the call up for anybody with questions, comments, thoughts. Like I said, this is one way of doing this. I do not claim that this is the best or the only way to do this, but wanted to open up the forum to any comments or questions.
Can
Yes,
you hear me?
Ken.
Yeah, Ken Hansen. I want to see what your thoughts are on intranasal, like for example, ketamine or fentanyl. I'm coming from an EMS background where we stick all sorts of things up people's noses, but I know, in hospice and possibly in palliative care, that's, we're more focused on comfort, and then people might be a little averse to, doing intranasal administration, but it's nice when you have no access, right?
Absolutely.
It's for many of the medications, the dosing is pretty similar. So I just wanted to see what your thoughts were on that.
I mean, I trained in the emergency department, like yourself, and I think, I abide by sort of the philosophy that any port in the storm, you use what you have. These medications are effective intranasally. They're used uh, a lot on the pediatric side when IV access is harder to get and cause trauma to patients. And so I I have not seen it in the community. Obviously, you see it more in an inpatient or emergency department setting. Um, and so we're kind of bound by what is possible in the community. But I think it's great. Intranasal medications are very useful when your other options may be limited. Um, Not just pediatric patients. Maybe you're caring for a cognitively impaired patient, where getting an IV placed is a tall order, or they're agitated or combative. Um, so I think, however you get the meds in, intranasal, intramuscular, sub-Q, IV, uh, as long as you can get it in and it is indicated for that medication, and we know that intranasal fentanyl is utilized quite a lot. I have less experience with like an intranasal ketamine, but certainly intranasal opioids, benzodiazepines, we know they work. They're absorbed pretty well through the nasal mucosa, and so certainly, I think, if it's available to you and you don't have other access, I think it may be challenging for repeat doses. Maybe, if you're considering intranasal, maybe that's the initial sort of loading dose, while you're working on achieving more sort of definitive access. But that's a great question. Anyone else?
What is the dosing for Precedex, please?
Um, so the short answer is that in our patient population, we don't know. It's not evidence-based. And it is, I don't want to lead you astray. It's because it's one of those sort of nuanced dosing. Like when you order it, it's mgs per kg per hour. And so we have, if I'm recalling correctly, we use it pretty infrequently, but I think our starting rate is 0.2 mgs per kg per hour. But I would, if you haven't ordered it before, this would be a great opportunity if you're even considering it. You're probably going to be calling your inpatient pharmacist anyway, because, at least at Corewell, our medication policy documents, and we're working on adjusting these, say that it's limited to the ICU. So, ordering it on many of our patients that we're caring for are not in the ICU. So I've spent several hours on the phone in these cases with inpatient pharmacy and sometimes nursing administration, especially if a nurse, a general medical or med-surg unit is not used to running these medications. And so clarifying with your resource teams like pharmacy first and foremost is recommended. But off the top of my head, I think that is what we use, 0.2 mg per kg per hour. Well, I once again I thank you all for your attention and time. This was fun, and if you have any questions, I'll put my email in the chat. But like all Corewell Health email addresses, it's usually first name dot last name at corewellhealth.org. But I will share that now and cede the floor to our next speaker. I think we're going to be talking about an interesting case. Thanks again.